Hello, my name is Devonne Hurst and I will be presenting on my quality improvement project, Outcomes Associated with Team-Based Cardiac Arrest Care Simulation. My committee members throughout this project were Dr. Jean Gordon and Dr. Jason Hebner. The second reader who helped me bring the project to its final and complete state was Dr. Maria Snell. This quality improvement project focused on the exploring of the effects Mach code simulation has, if any, on the compliance with the American Heart Association's, or AHA's, Advanced Cardiac Life Support, ACLS, algorithm, time guidelines, as well as ultimately the outcomes of the inpatient cardiac arrest patient population. There are over 200,000 cardiopulmonary arrests in the hospitals across the United States per year, according to the AHA. The survival rate for that population is 24.8% only. According to the AHA, this survival rate could be increased with more effective application and compliance with their ACLS guidelines. At the University of Maryland, Baltimore-Washington Medical Center, or UMBWMC, there was an opportunity to improve the cardiac arrest care. The time between the identification of the arrest and the arrival of the ICU code team was not being used effectively, which led to a suboptimal resuscitation effort. This lack of efficiency was identified as something which could be remedied by the institution of a practice program for the bedside healthcare worker. A complete literature review was performed using these four themes: use of Mach codes, use of simulation, ACLS guidelines, and importance of epinephrine administration and cardiopulmonary arrest as a basis for the research. There was no specific literature found which directly looked into the effect of Mach codes on patient outcomes, but there was a large amount of literature which investigated the benefit of Mach codes on nurse confidence and performance, retention of information, effectiveness of ACLS guidelines, and discussion on the effectiveness of early epinephrine administration. The main highlights of the literature review are as follows. Early epinephrine administration improves chances of an individual in cardiac arrest to return to a shockable heart rhythm, thus increasing their chances of achieving return of spontaneous circulation, or ROSC. Different dosages of epinephrine, as well as substituting vasopressin for epinephrine, have been explored over time, and the most effective medication and dosage, which per AHA guidelines, is 1 milligram of epinephrine every 3 to 5 minutes. Jacobs, Williams, and Perkins did find, however, that epinephrine given to a patient in a shockable rhythm, ventricular fibrillation, or ventricular tachycardia, could actually decrease the effectiveness of resuscitation effort due to the extra cardiac demand placed on the heart from the action of the epinephrine. This type of research is the research used to develop and support the ACLS guidelines from the American Heart Association. The AHA has created algorithms for resuscitation known as ACLS, and these algorithms are the foundation for the creation and performance of the Mach codes. The Parikh study in 2018 found an improvement in patient survival after an in-hospital cardiac arrest when healthcare staff were actually trained to use and apply ACLS, whereas before, no one was trained in the ACLS guidelines or algorithms. It wasn't being applied, and their survival rates were abysmal. Finally, exploration of the literature relating to Mach codes and simulation revealed the true importance of these two educational interventions. Herbers in 2016 found healthcare staff only retained approximately 14% of the information learned in ACLS after 1 year, and recertification for these life-saving skills is every 2 years. This loss of information could be remedied through the increased exposure and practice of ACLS skills outside of recertification classes. The AHA actually recommends the use of refresher activities between certifications to increase retention of ACLS skills. To conclude the discussion on the literature review, a majority of the sources reviewed, which focused on the performance of Mach codes to improve different variables like nurse confidence, recommended the performance of regular in situ or true-to-life Mach codes. The theoretical framework which helped guide the creation and performance of this quality improvement project was the Plan, Do, Study, Act, or PDSA, quality improvement model. This model was chosen as there is a defined goal and change sought with the implementation of a mock code program at BWMC. This theoretical framework is strict enough to guide the quality improvement project, but also flexible enough to allow for alterations during the project to provide the best results. Due to the ability of the PDSA model to have constant reassessment and alteration to its improvement model, it is an accepted framework to be used by the Quality and Safety Education for Nurses Institute, also known as the QSEN. Now on to the discussion of the actual quality improvement project. The population of patients were limited to the adult inpatient units within the hospital whom had participated in the education portion regarding mock codes and participation in cardiopulmonary arrests. The setting of the intervention was appropriate as it included the target population with unit educators who were invested in the development of this program. Unfortunately, due to the lack of resources available to the education department, the equipment used for the mock codes was largely improvised to achieve the desired effect. A mannequin for intubation was used to simulate the head and the airway of the patient. A CPR chest mannequin was used for defibrillator pad placement simulation, as well as positioning and performance of CPR with a feedback mechanism in place within the CPR chest. A phlebotomy mannequin arm was used for administration of ACLS medications. Simulated Bristojet ACLS medications were used and placed in the education code card. Bristojets are simply the delivery method for the ACLS medications which are provided to these nurses in the code cards during the event of a true cardiopulmonary arrest. Finally, a rhythm simulator was connected to the Zoll defibrillator monitor in order for rhythms to be displayed and assessed by the nurses participating in the mock code. The setting of the mock code occurred in the empty patient rooms on both day and night shift. The research subjects for this project were patients who experienced an in-hospital cardiopulmonary arrest. These patients who would have needed to be adults on adult inpatient units, and they required the application of basic life support and advanced cardiovascular life support during the period of the arrest. There was no limit placed on age, as age does not factor into the application of the BLS and ACLS protocols for patients who are full codes, meaning they wish for all life-saving measures to be performed. There needed to be documentation in the computer system, which could be transcribed to the master list for the hospital carrying the code blue metrics. The mode for the initial rhythm presentation within this group was pulseless electrical activity, and the rarest occurring rhythm was ventricular fibrillation. The initial cardiac rhythms which triggered an activation of a code blue were varied between pulseless electrical activity, asystole, ventricular fibrillation, and ventricular tachycardia. There was a total of 9 patients who had return of spontaneous circulation prior to initiation of the mock code program, and there were 9 patients after the initiation of the mock code program who achieved return of spontaneous circulation. This is out of a sample of 15 patients pre-mock codes and 15 patients post-mock codes. Quantitative methods data for the time to ACLS and BLS interventions, initial cardiac rhythm, and return of spontaneous circulation were obtained from the hospital database for their code blue metrics. A full Microsoft Excel spreadsheet is kept by the hospital and updated by the intensive care team periodically to reflect the trends in cardiopulmonary arrests at the University of Maryland, Baltimore-Washington Medical Center. The time to epinephrine, time to defibrillation, initial cardiac rhythm, patient location, time to CPR initiation, and whether or not the patient had return of spontaneous circulation are all metrics which are tracked by the hospital. The length of the cardiac arrests, as well as if the patient survived to discharge, is not considered in this study as it is beyond the scope, and more variables are introduced as more hospital care is introduced beyond American Heart Association cardiac arrest algorithms. An unpaired two-tailed t-test was performed on the pre- and post-mock code time to epinephrine administration and time to CPR. This test allowed for comparison of variables over time and pre- and post-intervention data which were not necessarily directly related. A chi-square test was performed on the rates of ROSC. There was a differentiation in the test performed on the data due to the types of data collected. The unpaired two-tailed t-test was appropriate for change with the population being measured of time, and the chi-square test was used for nominal data of the yes or no response for the rates of ROSC. The most promising outcomes were seen in the pre- and post-intervention epinephrine administration and CPR initiation. The intermediate values used for pre- and post-intervention epinephrine administration were T equal to 2.2146, degrees of freedom equal to 28, and standard of error difference equal to 0.692. The p-value for pre- versus post-mock code intervention of epinephrine administration times is 0.0351. where a p-value of less than 0.05 is considered significant. The two-tailed unpaired t-test was run against a 95% confidence interval. These results mean there is a statistically significant difference in the time of epinephrine administration before mock codes and after mock codes in favor of less time to first epinephrine after the mock code intervention. The intermediate values used for pre- and post-intervention CPR initiation were T equal to 3.55, degrees of freedom equal to 28, and standard error of difference equal to 7.30. The p-value for pre- versus post-mock code intervention of CPR initiation is 0.0014, where a p-value of less than 0.05 is considered significant. This two-tailed unpaired t-test was also run against a 95% confidence interval. These results mean there is a statistically significant difference in the time of CPR initiation before mock codes and after initiation of mock codes in favor of less time to CPR initiation after the initiation of the mock code program. Unfortunately, no difference in the rate of ROSC could be attained at this juncture. The p-value for the result of the comparison on rates of return of spontaneous circulation is not significant as the p-value is greater than 0.05. This means there was no statistically significant difference in the rates of ROSC before or after the initiation of performance of mock codes. Limitations exist on this sample, however, as it is quite small, so the power of the data is weak to draw conclusions about correlation from. There was also a lack of confidence in running an analysis on time to defibrillation, given the poor volume of data within the sample. A true comparison for pre versus post time to defibrillation cannot be performed as there were too few data points. In the pre-mock code dataset, there were 5 shockable rhythms, and in the post-mock code dataset, there were 2. Confident conclusions cannot be faithfully drawn from this data. The results of the study could have been affected in a variety of ways. Initially, the mock code program was effective and regular on the inpatient floors of interest, and the educators were reaching out to expand it to other floors in the hospital. Once the COVID-19 pandemic shut down the extracurricular activities within the hospital, it halted the progress of the mock code program as it did with many other programs within the hospital. This stopped the practice the floors were receiving on a regular basis with cardiopulmonary resuscitation. Once the data collection period occurred, there had been a large amount of staff turnover, and the ones who had stayed were out of practice with the skills required to be performed. Imperfections within the design of the study were present as well. There was not a backup plan for if a patient room was not available during the desired time to perform a mock code, so new areas had to be identified and improvised to perform the mock codes. Some educators were less willing to stress their staff than others, and many mock codes were canceled due to the high patient acuity on the unit during the desired time of performance of a mock code. The materials which were available to the researcher to create a mannequin with all of the necessary components to complete a high-fidelity mock resuscitation were at times off-putting to the staff when they entered the room, as there were pieces of different skill mannequins present in a patient bed. The awkwardness of resuscitating a mannequin in pieces became comical to some groups, and the educational aspect was partially lost due to the equipment that was present. The limitations were overcome as best they could be, considering a pandemic was still affecting the hospital, and its policies regarding educational activities and extra staff present in the hospital were changing every day. Once the visitor policy and the surge policies were lifted, mock codes resumed, and this researcher attended education fairs on the units to reintroduce the mock code skills. The educators began performing the mock codes again as they were able, and some were able to meet the 2 mock codes a month for a few months. Despite the tenacity of those present and who participated in making the mock code program a staple occurrence within the hospital, at this time the project results are just not generalizable. The sample size for this project, as I've said before, is quite small, as there are very few cardiac arrests in this hospital per month at baseline. There was a limited amount of time for data collection due to the constraints placed on the timeline for this project. And the COVID-19 pandemic also hindered the project's ability to host as many mock codes as was originally planned due to the cancellation of most in-person extracurricular activities outside of attending just your scheduled work hours. What has been found in this preliminary set of data is that the initiation of mock codes and increasing the amount of time nurses worked with ACLS is, in an as true to life as possible situation, did improve some measurable interventions which carry a heavy weight in the ACLS algorithm. Firstly, the time to initiation of CPR greatly improved, meaning there were nurses and healthcare staff getting organized in the room faster to provide the patient with CPR. The time to first epinephrine administration also decreased after the initiation of mock codes, meaning the life-saving ACLS medication was getting into the patient's circulation faster. These are promising trends in such a small amount of data. Even though there were limitations to the sample size of the data presented, there is a program in place which can continue to collect data in the future, allowing for a reassessment of the impact of these mock codes on the compliance and performance of ACLS interventions. In the future, it would be important to continue data collection to truly observe the impact of mock codes on the response of staff to cardiopulmonary arrests on the adult inpatient population. The impact this could have on safety and healthcare is vast. The American Heart Association discusses all of the opportunities present per year for more people to survive from a cardiopulmonary arrest, but they do not. Potentially, with the continued practice and exposure to these life-saving skills and medications, the nursing staff at BWMC will be able to change their rates of ROSC for the better. It would mean more lives saved by staff who have been properly prepared to respond effectively to an adult inpatient cardiac arrest. If ROSC rates can be improved, then more lives can be saved. At this time, I will provide a few minutes for anyone to ask any questions. Let me know in the comments.